All right, good afternoon, and thank you for joining us today for the presentation covering Indiana's updated gonorrhea treatment guidelines, hosted by HCET with presenters Dr. Sancta St. Jamie Black, and Dr. Christine Heumann. My name is Brandon Heinbaugh, and I'm a project manager at HCET, and I will be moderating the webinar today. Let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. For more information and to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website at hcet.org. For additional training and professional development opportunities, visit our virtual learning website at learn.hcet.org. Now I will quickly review some housekeeping information. If you would like to receive nursing contact hours for this webinar, please complete the form that was sent with the login information and fax it to the number listed at the top of your screen, or email it to kbradford@hcet.org. A link to complete an event evaluation will be sent to you via email following this webinar. Your feedback is greatly appreciated. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please contact us at the email listed on your screen. In order to receive nursing contact hours for this webinar, participants must attend the entire webinar, complete the event evaluation, and submit the nursing contact hour form to HCET. The presenters today do not disclose any actual, potential, or perceived conflicts of interest. Throughout the presentation, we encourage you to send your questions via the chat box. To submit a question, hover over the main screen, then select the blue chat icon. Once selected, the chat box should appear on the right side of your screen. To send a question at any time during the presentation, please send it to all panelists. This ensures everyone behind the scenes can view your question. We will hold all questions until the Q&A portion of this presentation. Now I would like to introduce you to your presenters for today. Dr. St. Cyr is the project officer for the gonococcal isolate surveillance project, the National Sentinel Surveillance System for Antibiotic Resistant Gonorrhea. She joined Division of STD Prevention at the CDC as a medical officer in 2017. In her role, she regularly contributes to programs and publications involving antibiotic resistant gonorrhea and recently co-led the gonorrhea subcommittee for the upcoming CDC's 2021 STD treatment guidelines. She earned her medical degree from Louisiana State University Health Sciences Center in New Orleans, trained in internal medicine at the Mayo Clinic in Rochester, Minnesota, and completed her infectious diseases fellowship and Master of Public Health and Epidemiology at the University of North Carolina at Chapel Hill. Next, we'll be hearing from Jamie Black. Jamie is a Hoosier native who began her career in public health working with both nonprofit organizations and local government agencies in disaster preparedness and epidemiology. She completed her MPH in epidemiology at SUNY Downstate School of Public Health in Brooklyn, New York, and soon after joined Indiana Strengthening the U.S. Response to Resistant Gonorrhea Surge Team at the Indiana State Department of Health as the project's epidemiology coordinator. She also supervises the STD Surveillance Network grant and recently became one of 13 epidemiologists chosen for the inaugural Council of State and Territorial Epidemiologist LEAD program. Jamie also holds a Bachelor of Science in Genetic Biology from Purdue University with a minor in anthropology. And then rounding out today's webinar, we'll be hearing from Dr. Christine Heumann. Dr. Heumann is an assistant professor of clinical medicine at Indiana University School of Medicine. She obtained her medical degree from IU School of Medicine. She then completed her internal medicine residency at Northwestern University and infectious diseases fellowship at the University of Washington. While at University of Washington, she also earned a master's of public health degree in epidemiology. From 2016 to 2018, she was an assistant professor of medicine at Wayne State University School of Medicine and medical director of the Detroit Public Health STD Clinic. She is now medical director of the Bellflower Clinic in Marion County STD Control Program. In addition to providing care to patients at Bellflower, she practices general infectious diseases at Eskenazi. Her research interests include STD epidemiology, HIV prevention, and PrEP implementation. So without any further ado, I will give things over to our first presenter, Dr. St. Cyr.
Thank you. So sorry about that, you guys. I was muted. So hi, everyone. Good afternoon. I just want to say thank you for that introduction, Brandon. And I'm just honored to be here. So thank you to the organizers for inviting me. I have a lot of stuff that I want to jump into. So I guess let's go ahead and get started. So the first thing I think that everyone should get from this presentation is that Neisseria gonorrhoeae has developed resistance to all drugs that have ever been used for treatment. And so this is something that has helped us just recognize that we need to stay on top of gonorrhea, that we need to stay in front of resistance as it develops, because it's not necessarily if it develops, but more of when. And that also impacts the public health responses that we recommend. So we recently released our case report data in April of this year, and that's shown that gonorrhea cases that have been reported to CDC have continued to increase over the past several years. We also earlier this year released our estimates data. Sorry, there's a lag here. So we also released our estimates data earlier this year that show that there are about 1.6 million incident gonococcal infections that are reported in the US, and this is based off of our 2018 data. And we also know from using GIST data in these estimates that there are over 800,000 cases of these incident infections that have resistance or reduced susceptibility to at least one antibiotic. We were also able to estimate the direct cost of gonorrhea in the US. And when we look at gonorrhea combined with chlamydia, it's about $1 billion in direct costs based in 2019 dollars that we have here. And so when we take into account that antibiotic resistant gonorrhea is more complex in order to manage and treat, then we know that the burden and the risk for spreading infection, having it lead to complications, and also just the staggering cost of it all can increase those numbers that I just showed you. So I'll jump into what the actual treatment recommendations are, and then eventually I'll show you guys the data that we use to come up with the treatment recommendations. So previously, starting in 2020, the CDC recommended dual therapy for managing gonorrhea. And the idea was to use 2 different drugs with 2 different mechanisms of action for the theoretical benefit that it would help slow down or decrease the risk of resistance developing to gonorrhea. And we know that cephalosporins, which are the backbone of gonorrhea treatment, are our last defense. And so we wanted to maintain those drugs for as long as possible because the pipeline for new drugs have been pretty slow to develop. So some of you guys may have seen some of these cases in 2018, but there were reports out of the UK and out of Australia that showed that gonorrhea cases where they were treated with a ceftriaxone-based therapy, and in a lot of cases also had that second drug for dual therapy, were failing treatment. And so there was concern about, are we getting past the point where dual therapy is working? Are we at the point where we need to start thinking about what are we treating gonorrhea with? So I want to just highlight this table here that just shows the different published reports of gonorrhea cases that have failed ceftriaxone-based therapy. And here, I just want to point out, I know it's a busy slide, but I just want to point out that the majority of the cases involved infections at the pharyngeal site. And so this has got the gonorrhea community really thinking about what is going on in the throat, what's going on in the pharynx. Is it due to poor drug penetration that we see that patients are failing at this anatomic site? Or is it due to something else? Is it due to the fact that gonorrhea is living in an environment where there are other bacteria there and it can share resistance genes across the different species? So the idea is that something is going on here. We want to pay close attention to the pharyngeal site. And so based off of that, we wanted to let our public health response and let our treatment recommendations highlight the need to focus on this anatomic site more. So in December of 2020, we released our updated gonorrhea treatment recommendations. And this is just a teaser or a snippet of the full treatment guidelines that'll be coming out later on this year. So as part of the new recommendations that were released, you'll see a couple things here. First is that we increased the ceftriaxone dose from the previous 250 milligram to 500 milligrams. We also recognize that patients who weigh more than 150 kilograms or 330 pounds may not get the optimal drug concentration that's needed. And so there's a weight-based dose component here, where if you have a patient that's above this weight limit, we recommend increasing the ceftriaxone dose to 1 gram. What you see here also is that we do not have azithromycin as part of the recommended regimen anymore. It is now a monotherapy treatment. We do have some alternative regimens that were also released in December. One option is Ceftriaxone 800 milligrams given as a single dose. Another option is gentamicin plus azithromycin. I will highlight here that these options are only recommended for urogenital or rectal sites. So if you have a pharyngeal infection, this is not recommended here. I also want to take this time to note that if you are concerned that a patient may have a ceftriaxone or cephalosporin or beta-lactam allergy, we really encourage you to dig into the history to see, because you can see here on this screen that we have limited options for patients who have a true allergy. And I will note that a cephalosporin or a true beta-lactam allergy is very rare. And if it's not an IgE mediator or not documented where there's like anaphylaxis or anything concerning like that, you can still likely give a cephalosporin regimen. In addition to that, we also noted that if someone has chlamydia or has not been ruled out for chlamydia, you still should treat for chlamydia when you are managing gonorrhea. Previously, the azithromycin that was part of the gonorrhea recommendation was able to cover that, but based on the data that'll come out later on and with the 2021 recommendations in the chlamydia section, it is recommended that doxycycline 100 milligrams twice a day for 7 days be considered for chlamydia treatment. As mentioned earlier, we are very concerned about the pharyngeal site. We know that this is a site where there's very few symptoms, And we're also concerned that this is a site where resistance may be developing or where treatment failures can occur. And so we have 2 points that we wanted to highlight. One is something that I mentioned earlier, which is that we don't have any alternative regimens for treatment of gonorrhea at the pharyngeal site. If you are concerned that you need to give a different regimen than the Ceftriaxone recommended, we would suggest that you reach out to your infectious diseases partners or the prevention training centers or someone else who is very knowledgeable in the management of gonorrhea so that they can help you come up with a regimen that would work. In addition to that, we also put language in these new recommendations around test of cure. So with the previous guidelines that came out in 2015, we recommended test of cure at the pharyngeal site when a patient was treated with an alternative regimen. Now we've said that all pharyngeal infections, no matter what they're treated with, receive a test of cure. And we recommend the window for doing test of cure to be between 7 and 14 days after treatment. I will say that different sites can do test of cure using different testing modalities. So some people may use culture, some people may use a DNA NAT, some people may use an RNA NAT. I will say that with NAT, you should be aware that there is the risk of having a false positive because there can be some remaining genetic material that can be collected, especially if you do the test of cure earlier in this window period. So if you were testing with a NAT, you can consider doing your test of cure at 10 days or later, but recognizing there are risks that come with that, meaning that there's the higher risk that your patient will begin sexual activity again and increase the risk for reinfection during that timeline. So weigh those pros and cons when you are managing a case in front of you. And then the last thing I just wanted to highlight with the new recommendations is the repeat testing at 3 months. This is not anything new, and this is a recommendation that's been around for some time, but I just wanted to highlight it here because it's one that's missed frequently. And so one of the suggestions that we offer is to schedule this repeat testing in 3 months at the time that the patient is in your office or in your clinic. And that way it's almost like going to the dentist. They know that they need to come back. So again, this is what the previous 2015 recommendations were. And now I just want to show you how we got to the current recommendations. So one thing that we took into consideration were our GIST data, which are our national surveillance data that we get for antibiotic resistant gonorrhea, which has in the past been used to help come up with treatment recommendations. But in addition to that, this time around, we also looked at pharmacokinetics and pharmacodynamics data. And then we also looked at the treatment guidelines from a different perspective, and that was through the lens of antibiotic stewardship. And so that's how we arrived at this higher dose of ceftriaxone. And I'll quickly go through these different areas just to show you the data that we looked through to come up with this. So first, looking at the GIST data. So GIST, like I mentioned, is our national surveillance system that's been in place since the late 1980s. And it was created for 2 main purposes. One, to monitor trends in gonococcal susceptibility, but also to be used to come up with a rationale for treatment selection. And so gonorrhea has been used since its inception to inform treatment guidelines. And this is just an image of the different guidelines that that GIST has helped out with over the years. So this slide is a little bit busy, but I just want to highlight 2 things here. So in the green sections, when we look at 2009, which was considered our historic low year for reported rates of gonorrhea in the US, and compare it to our most recent data of 2019, we see some differences here. So the green section are the percentage or prevalence of isolates in GIST that were considered to be susceptible to all antibiotics tested. And you see 3/4 were susceptible 10 years ago, and now less than half are. Another concerning trend that we see is when we look at the percentage of isolates that have resistance or reduced susceptibility to 2 or more antimicrobials, it was 10% in 2009 and 21% in 2019. Another way that we can look at the trends and data is just to see visually what has been happening over the years. And so On this slide, I show just data from essentially its inception in the late 1980s until now. And I won't focus on all the lines here, but just to say that tetracycline and penicillin have been relatively stable, even though there's some fluctuations, but they've also been relatively high when it comes to resistance circulating in the US. The red line is ciprofloxacin, and we see that that line has been trending upwards over the past several years, even though we don't use those use fluoroquinolones for treatment anymore. But what I'll really spend some time showing you are the antibiotics that we've used more recently for treatment, and that's our cephalosporins and azithromycin. So here in the green bars is Ceftriaxone, and in the gold bars is Ceftriaxone. And I just also want to highlight that on the y-axis, we're looking at percentages of about 1% or lower here. And you see that in 2011 with Ceftriaxone, we had a relatively higher percent for cephalosporins at 1.4% with reduced susceptibility to this drug, and that trended down. And we like to think that our recommendations to remove Ceftriaxone as a recommended drug play a role in this. And as you see, Ceftriaxone in the gold bars has remained relatively stable and low over the past several years. I'll quickly go through the next two slides just to show that when we look at certain populations, we see some differences here. So among men who have sex with men and among men who have sex with women, we see different trends when we're looking at reduced susceptibility to Ceftriaxone. In the blue bars, men who have sex with men have a higher prevalence of reduced susceptibility to Ceftriaxone compared to Ceftriaxone, compared to men who have sex with women. And we see the same trend when we take a look at it with Ceftriaxone. Again, men who have sex with men have a higher percentage compared to men who have sex with women. But now if we add azithromycin to the slide and we look at the trend that we're seeing with azithromycin, it's telling a different story than what we saw with the cephalosporins. And so the purple bars here are azithromycin. And if you look at 2012, there was a prevalence of 0.3% of isolates having reduced susceptibility to azithromycin. And that has just continued to go up over the years, all the way up to our most recent year of 2019. I will pause here and say that there is this theoretical, hypothetical line at 5% that we use just to kind of take a look at antibiotics to say, should we continue using this or should we start looking at, is it time to consider its role in treatment of gonorrhea? And as you see with azithromycin, we crossed over that arbitrary 5% line. And again, the same pattern was seen among men who have sex with men, having a higher prevalence of reduced susceptibility that we saw with the cephalosporins. We see the same thing here with azithromycin. And then also with azithromycin, I just wanted to show that we see different trends by region. In the South, they tend to have a lower prevalence of reduced susceptibility to azithromycin. It's slightly higher in the Midwest, even a little bit higher in the Northeast, and then the West has the highest at 6.9%. But I will point out that all regions were above that 5% arbitrary cutoff at one point in time, except for the South, again suggesting that we should take a look at the use of azithromycin moving forward. So I'll quickly also go through the pharmacokinetics and pharmacodynamics. This is a new area that we looked at for these treatment recommendations. So first thing I want to point out is the differences in the half-lives in the two drugs that we were using previously for gonococcal treatment. So azithromycin has a 68-hour half-life compared to Ceftriaxone that had an 8-hour half-life. So what that means is that when we were given Ceftriaxone and azithromycin together, the azithromycin hung around much, much longer than the Ceftriaxone was. And this meant that you were essentially receiving azithromycin monotherapy for days and days after the Ceftriaxone was gone. And at this time, it was also coming in at subtherapeutic levels, which could kind of select for isolates or samples or gonorrhea to develop resistance. The next thing I'll focus on is just with Ceftriaxone here. So we looked at the PK/PD information with ceftriaxone. So specifically with ceftriaxone, we like to look at how much time, how much concentration and time above that MIC we have. And so we looked at two main papers. One is the Chisholm paper where they do Monte Carlo simulations and found that the optimal time for clearance of infection was around 20 hours. There was also the Connolly paper that used a murine model that looked at different concentrations and found that within that 48-hour period, that 100% clearance occurred at about 24 hours above the MIC. And so if we take a look at first the Chisholm paper, when they were looking at the MIC or minimum inhibitory concentration of 0.03, you'll see that the median time above the MIC was 41 hours, which is above that 20 hours that we think is needed to clear the infection. But when we look at the 95% confidence intervals, you'll see that at the lower end, it falls below, just slightly below that 20 hours. So this shows that there may be some inter-individual pharmacokinetic differences here, meaning that there may be some patients that would fall towards this lower end and may not be adequately treated with a dose when they're treating an isolate that has this particular MIC. When we take a look at the Connolly paper, they found that optimal clearance occurred with the 5 milligram per kilogram dose that were given to the mice in the study. And if you look at what that equals to when we compare that to doses for humans, that 5 milligram per kilogram dose of 250 milligrams would work for someone of 50 kilograms. But in the US, we know that body weights have been going up, and now the average American is about 80 kilograms. And so that recommended 5 milligram per kilogram dose to clear the infection would actually be underdosed for someone that's 80 kilograms. And so essentially we were previously with the 250 milligrams providing about a 240 milligram regimen is about that 3 milligram per kilogram dose. And so if we take a look back at the Monte Carlo simulations that we saw looking at different MICs, with the higher doses in ceftriaxone, we can look at the 500 milligram and the 1 gram dose. To the left, you'll see that the 500 milligram dose had that time above the MIC of about 41 hours and 32 hours. But then again, if we look at that 95% confidence interval at the lower end, we're either at that 20 hours or we're lower than the 20 hours, suggesting that this dose for some individuals may not be high enough. But then if we go up to that higher 1 gram dose, again, looking at the median that's well within the 40 hours, you'll see that the lower doses, especially at that higher MIC of 0.125, falls below that 20 hour that we would like. And so suggesting that we don't get as much bang for our buck when we go up to a 1 gram ceftriaxone dose compared to the 500 milligram dose. So based on GIST data, we know what the MICs of circulating isolates are. And if we look at the most recent data, we see that 90% of the isolates have an MIC of 0.03 or lower, even though we have a few at that higher end, suggesting that that 500 milligram dose that we're recommending would be adequate to clear the strains of gonorrhea that are circulating around here in the US. I will just highlight that after we came out with these recommendations, we did note an isolate in GIST coming from Las Vegas that was found to have a much higher ceftriaxone MIC of 1 and a cefixime MIC of 2. We haven't seen any more of these circulating around, and when we did an investigation, we could not find any other isolates or any other cases with similar MICs. But again, just highlighting that we need to always be thinking about resistance developing here in the US and always making sure that we're trying to stay in front of it before it spreads further. So lastly, and I know I'm running up against time here, but I just wanted to highlight that we really took a different approach to looking at antibiotic stewardship when it comes to the treatment recommendations. So we know that gonorrhea is probably the poster child for antimicrobial resistance among sexually transmitted infections, but is also not the only one. And you will see that azithromycin is used for treatment in more than one infection, especially in the setting where patients may be co-infected with more than one organism. So quickly here, I just want to show that enteric pathogens can be transmitted sexually. So Campylobacter, Shigella are the main ones. And we're dealing with antimicrobial resistance there with fluoroquinolones and with azithromycin as well. And so this is not just happening here in the US, but it's happening in other countries as well. And so we even see that these resistant mutations are spreading across borders. So again, resistant organisms don't care about what country it originates from. There's still the potential of it coming here to the US. This particular study was done in 6 STD clinics here in the US, where they were looking at Mycoplasma genitalium. That is another infection that is getting a lot of attention now, and that we're treating with fluoroquinolones and we're treating with azithromycin. And just here, I just want to show you that the 23S mutations, which lead to azithromycin resistance, were found in about 60% or more of the isolates collected as part of these studies. And so again, if we're giving a drug that is known to have resistance in other organisms, are we doing harm not only to just gonorrhea, but to other infections that our patients may have? And then lastly, I just wanted to show this. This was another study done in sub-Saharan Africa where children were being given azithromycin as a way to decrease childhood mortality. And they compared the doses or the giving of azithromycin to placebo. And at the end of the study, they found that the children who received azithromycin not only had a much higher twofold increase in beta lactams, they also had a 7-fold increase in azithromycin and a 4-fold increase of metronidazole resistance. And so by giving azithromycin in this setting, they were able to recognize the resistance developing in the drugs that they gave, but also in other drugs that aren't necessarily related. So there is an impact on the microbiome of these children, but also of other antimicrobials that they could get as well. So I know I'm running out of time, so I just want to say what's now and what's next. So be on the lookout for the full 2021 treatment guidelines that are coming out later this year. At least for the gonorrhea section, we'll have more information about the management of disseminated gonococcal infections, or DGI. We'll also have some information about ciprofloxacin use, when that should be considered and when it should not, and then just other diagnostics that are new with gonorrhea. There's also been a lot of discussion about the chlamydia recommendations, especially with us stating that doxycycline should be considered for chlamydia treatment. So stay tuned for the evidence and the data that will support the recommendations that the chlamydia group have come up with. And then just lastly, everyone should be on the lookout for suspected treatment failures. And I know we highlighted test of cure at the pharyngeal site as a way to look for treatment failures, but they can occur at any anatomic site. And so if you have persistent symptoms or you have a positive test of cure, please make sure that you take a good sexual history and rule out reinfection. If you're not too concerned about treatment failure, more concerned about reinfection, you can retreat with that initial regimen, but make sure to collect a sample for culture if you think this could be a true treatment failure, and also get a simultaneous NAT. That way, if it is a treatment failure, we can start looking at what resistance mechanisms can be there and what alternative regimens we can use. And you can consider giving gentamicin and azithromycin for a case that's right in front of you while you're waiting on results from the culture and from the NAT. And if any of this is confusing, or if any of this seems like more than what you can handle, please reach out to us either at CDC, because we want to know about potential treatment failures, but also reach out to your local experts, your infectious diseases physicians, your prevention training centers, or anyone else who is very knowledgeable in gonorrhea treatment. So just be on the lookout again for just the rising rates of gonorrhea, please take into consideration our recommendations for that increased ceftriaxone dose, not using azithromycin as part of gonorrhea treatment, and making sure that there's a plan in place for pharyngeal test of cure. And then again, treatment failures are a real concern here in the US. So keep that in mind because we have limited treatment options and it's important for us to identify these cases quickly. So thank you.
Awesome. Thank you so much, Dr. Sear. That was such a great presentation. So many wonderful examples and things for all of us to kind of move forward with as we continue to help treat the patients in our communities. So with that being said, I would like to now welcome Jamie Black to go ahead and start her portion of the presentation.
Thanks, Brandon. Hi, everyone, and thank you for being with us again on this webinar today. My name's Jamie Black, and I'm one of the epidemiologists on the STD prevention team here at the Indiana Department of Health, where I coordinate the state and local efforts for the CDC-funded project Strengthening the U.S. Response to Resistant Gonorrhea, or SURGE. And so today I'm going to be going over the procedural updates and changes that we as a state have made to coincide with the new recommendations issued by the CDC when it comes to treating gonorrhea. So I have three main objectives to walk you through today, and these include describing operations within our program's work that have been impacted by the gonorrhea treatment guideline changes and how we've adapted to them, describing best practices for gonorrhea case management at the state and local level, and introducing gonorrhea-related projects at the state that are in the works for the future. So first up, I will go over changes that the state has made to coincide with the newest CDC recommendations. So there were four main changes that we've rolled out in the state since the treatment guidelines were updated in December 2020, and I'm going to briefly touch on each of these. First up, I'll cover the updates that needed to occur to our public-facing information sources at the State Health Department. As soon as the MMWR detailing the newest guidance on gonorrhea treatment guidelines was released back in December, we needed to get this information to healthcare providers in Indiana as soon as possible. This included updated information on treatment guidelines for gonococcal infections on our STD prevention program's webpage, available from in.gov/ISDH. This included removing all mentions of azithromycin as a recommended therapy for gonorrhea and updating the dosage of ceftriaxone. The information that is on our website now mirrors the content on the CDC's website. We also made similar changes to our downloadable provider resources on our website. Once the resources were updated, we issued an advisory through the Indiana Health Alert Network, or IHAN, about the treatment guideline changes. And I also presented these changes on a recent webinar through the Midwest AIDS Training and Education Center, or MATEC, in Indiana as part of their STD intensive series for practitioners. Next up, the changes that we made to our surveillance system for disease reporting. So to accommodate the new recommendations made for gonorrhea treatment options, we added new first-line and alternative therapies as options to select for treatment of gonococcal infections in the state's surveillance system, NBS. We also added those same options to our online communicable disease reporting form for providers. And then next on the list of changes are options for expedited partner therapy, or EPT. So my hope is that most people on this call are aware that EPT is legal and supported in Indiana. But for those that are unfamiliar with this practice, EPT is treating sexual partners of patients diagnosed with an STD, specifically chlamydia and/or gonorrhea, without an intervening medical evaluation. This practice helps prevent reinfection of patients and is considered an effective partner management strategy. Prescribing treatment to partners is a protected activity under the Indiana Administrative Code. With the new recommendations, the STD prevention program aligned their EPT guidance to be consistent with the current treatment therapies for gonorrhea. The updates reflected in the EPT guidance include the following. For patients diagnosed with gonorrhea only, all sexual partners within the past 60 days should be treated with 800 milligrams of Ceftriaxone only. If the patient is co-infected with chlamydia, or for some reason a chlamydia infection cannot be ruled out for the index patient, treat all their partners within the past 60 days with an additional regimen of doxycycline. Treatment for the partner would then be 800 milligrams of Ceftriaxone plus 100 milligrams of doxy twice a day for 7 days. Please note that the full 2021 STD treatment guidelines will come out later this year with updated treatment recommendations to all STD infections, but the gonorrhea treatment changes are the only current changes within EPT. Chlamydia-only EPT guidance within Indiana is still the same as before, 1 gram of azithromycin or 100 milligrams of doxy twice a day for 7 days. As a note, pregnant women should only be given azithromycin for treatment of chlamydia and not doxycycline. Once the CDC releases the full guidelines, the STD program will provide further updates via IHON. And for the last of the major changes, I'll cover the recommendation for a test of cure for cases of pharyngeal gonorrhea. And as a note, gonorrhea may be abbreviated as GC moving forward. So another important change to highlight is this new recommendation for a test of cure for pharyngeal gonorrhea infections. The recommendation is to collect a gonorrhea culture and simultaneous nucleic acid amplification test, or NAT. We know not everyone has access to culture testing, so we recommend NAT testing to be done between 10 to 14 days after receiving treatment, regardless of the regimen the patient originally received. Although gnats are more sensitive and can pick up dying bacteria up to 3 weeks post-treatment, our Indiana Surge program has used this practice of 10 to 14 days for a test of cure window and has had minimal false positive results. This is slightly different than what Sancta mentioned earlier, but the 10 to 14 day time window is something we've been able to test out in the last 5 years of our grant, and we found it was the optimal time frame for minimal false positive results. If a test of cure is collected more than 30 days after treatment and the patient is positive for gonorrhea, this case should be reported as a new infection. As a note, the test of cure is different from the previous recommendation of a retest in 3 months, which was included in the 2015 treatment guidelines. As Sancta mentioned earlier, the retest is important to continue as a best practice due to the increasing rates of people being reinfected with gonorrhea, commonly because they've engaged in sex with untreated partners. The best way to think about the difference between a test of cure and a retest is a test of cure would answer the question, did the patient clear their current infection? Whereas a retest would answer the question, does the patient have a new gonorrhea infection, potentially due to re-engaging in sex with untreated partners? So next up, I'm going to describe the continued best practices for gonorrhea case management that should occur at the state and local level. As you can see from the figure below, taken from the CDC's recently released 2019 STD surveillance report, azithromycin resistance has increased steadily since 2014 and has reached its highest level in 2019 at 5% of isolates collected showing reduced susceptibility to the drug. With the rapidly declining power of azithromycin, the CDC recommended the removal of azithromycin as a frontline treatment option for gonorrhea. This underscores the importance of making sure healthcare providers are adhering to recommended treatment options for gonorrhea and taking steps to improve the monitoring of treatment failures in our state. When it comes to treating people with allergies, it's very important to adhere to recommended therapies. The CDC provided some additional guidance in their update around patients with medication allergies and treating for gonorrhea. Similar to the 2015 guidelines, the CDC offers alternative regimens for treating patients with gonorrhea who have either cephalosporin or penicillin allergies. Some symptoms to look out for in the patient's history that would be considered a severe enough allergy to warrant alternative regimens would include edema, hives, or symptoms of anaphylactic shock. In this case, if a patient has either a urogenital or rectal gonococcal infection, the CDC recommends 240 milligrams of gentamicin plus 2 grams of azithromycin. If the patient has allergies and a pharyngeal infection, no reliable treatments are available anymore, and at this point, the provider should consider desensitization if necessary. With the increasing antibiotic resistance trends, monitoring for treatment failures is a priority. It is important to point out that true treatment failures are extremely rare. When my program is looking into potential cases of treatment failures, we consider the following scenarios as defined by the CDC. If a patient's symptoms do not resolve within 3 to 5 days after appropriate treatment and report no sexual contact during the post-treatment follow-up period, which is typically 7 days, or if a patient has a positive test of cure when no sexual contact is reported during the post-treatment follow-up period, or if the patient has a positive culture on test of cure if that was obtained, and evidence of decreased susceptibility to cephalosporins upon antimicrobial susceptibility testing, regardless of whether sexual contact is reported, should be considered as treatment failures. If you suspect a patient has a treatment failure, report the case to the STD prevention program through me within 24 hours of test results. Lastly, I will introduce some projects we have in the development stage at the state that are related to gonorrhea surveillance and outbreak preparedness. As the threat of antibiotic-resistant gonorrhea continues to evolve, the State Health Department plans to establish a centralized repository of information and best practices when it comes to gonorrhea case management and outbreak preparedness, fittingly titled the Center for Gonorrhea Excellence, or CGE for short. This repository would include resources directed towards healthcare providers, up-to-date trends on gonorrhea morbidity and antimicrobial resistance surveillance, resources for disease intervention specialists to use when talking to patients about gonorrhea and resistance, resources for outbreak preparedness and pre-approved media messaging templates, as well as general STD facts, including information on syphilis. For today, I just want to talk a little bit more about some of the exciting projects in the pipeline when it comes to those provider resources. Some of the proposed content that would be ideally included as part of the Center for Gonorrhea Excellence under these provider resources would be downloadable treatment guidelines and information on how to report STDs via the online communicable disease reporting form or the web CDR. A new proposal would include an option to request expert medical advice from an infectious disease doctor who specializes in STDs and is familiar with resistant gonorrhea and the latest guidelines on case management. Another new proposal is to have an option to request gonorrhea culturing supplies, including those determined as best practices by the SURGE program for gonorrhea isolation, to submit patient samples for antibiotic susceptibility testing. These samples would be processed by the Marion County Public Health Lab, which performs all our local testing for SURGE currently. This type of sample would be a good option to use if you have a patient that could be a potential treatment failure. So that's all the information I have from the state's perspective. So if you have any questions, you can leave them for me in the chat box for the Q&A session at the end. And otherwise, I've included my contact info here for questions after today. And next, I'll be handing it off to Dr. Christine Heumann to talk about the local response. Thank you.
Thank you so much, Jamie, for giving us that insight into Indiana and how things are kind of operating here. I know that's going to be very helpful for a lot of our public health and clinical folks that are on this webinar today. So with that being said, we will move on to our final presenter to give us a little bit more of a clinical insight into the implementation of these new changes. So Dr. Heumann, you are free to go.
Great. Thank you, Brandon. So as Brandon had mentioned, I'm going to focus on the implementation of these new guidelines in a clinical setting. And the clinical setting that I'll be talking about is Bellflower Clinic, which is our public health STD clinic here in Marion County. We also serve the entire District 5, so that's Marion County and all of the surrounding counties in the Donut area. At our clinic, we offer full service visits with clinicians for anyone with symptoms of an STD or known contact to an STD. We also do screening visits Those are for asymptomatic patients or who have no known contact to an STD. So that's just a quick express visit to get testing. And then our site is also unique in that we have an on-site laboratory, including male urethral gram stains for the diagnosis of gonorrhea. And then we have treatments and vaccines available on-site as well. With the changes in the gonorrhea guidelines, we had to consider several things at the clinic level. And I wanted to talk about a few of those today, including some of the considerations around increasing the ceftriaxone dose, when we should be giving doxycycline in addition to the ceftriaxone, some EPT considerations, and how we are implementing the test of cure at our clinic for pharyngeal gonorrhea. Starting with ceftriaxone dosing. As has already been described in this presentation, the new recommendation for treatment of uncomplicated gonorrhea of the cervix, urethra, pharynx, or rectum is ceftriaxone 500 milligrams IM for persons who are less than 300 pounds, or a gram for those over 300 pounds. Before this guideline, we weren't weighing patients at all in our clinic, but now we do have a scale available. If we think a patient might be on the cusp of one of these two doses, we have a scale available to help with our dosing for treatment of gonorrhea. We also had to consider how we were going to prepare and administer the ceftriaxone at this new higher dose. We had many vials of ceftriaxone, 250 milligrams per vial, remaining at our clinic at the time of the new guidelines. So we had over 100 vials of this, and we had to figure out how we could use these up to get the newer higher dose. So we talked with our hospital pharmacist, and we were able to reconstitute 2 vials separately, each in 1 milliliter of lidocaine, and then combine those 2 together into a 2 milliliter injection to give the higher dose. And then once we were able to purchase new vials of ceftriaxone at the higher dose, we're now able to give it in 1 milliliter of lidocaine as a single injection. Or if we need to double up to the 1 gram, then again, it'll be in the 2 milliliters. This could be different depending on the product you order. I just recommend, if you're making this switch at your clinic, to confirm that you are properly diluting and administering the higher doses. Next, I'll talk a little bit about when to give doxycycline. As we heard earlier, the newest guideline is to give doxycycline if chlamydia infection has not been excluded. And this is a shift from how we used to practice. So we used to give ceftriaxone and azithromycin for the treatment of gonorrhea, which also happened to treat chlamydia. And that was very easy in clinical practice. Now we have to think about it a little bit more and think about when should we be giving this doxycycline, or when is monotherapy with ceftriaxone appropriate. So a couple of the scenarios that we had to think about with this transition in the guidelines is, how would we be treating patients who had positive gram stains, so those who had evidence of gonorrhea on their gram stain, and how would we be treating context gonorrhea? So as far as those who have a positive gram stain during their clinic visit, so this would be a male with discharge, and we're seeing evidence of gonorrhea on the stain, we are not able to rule out concurrent chlamydia infection based on just that test result. That's not something we can see on the gram stain. So in this scenario, we know the patient has gonorrhea, but we cannot rule out chlamydia. So we go ahead and treat with ceftriaxone and the 7 days of doxycycline. The other question that came up frequently as we were transitioning to these new guidelines is, how should we be treating asymptomatic contacts to gonorrhea? Can we rule out chlamydia in those partners? So sometimes at our clinic, we're seeing contacts to people who have a positive gram stain, but their NAT results aren't back yet. So chlamydia has not been ruled out in the primary patient. So in that case, we would also treat the partner with ceftriaxone and doxycycline. However, if we have a partner or contact to gonorrhea, and we know that the original patient had a negative test for chlamydia, only positive for gonorrhea, then we would treat with ceftriaxone alone for that partner. The exception in all of these cases would be pregnant women for whom which we would give azithromycin 1 gram rather than the doxycycline course. As far as EPT considerations, Jamie already talked quite a bit about the new EPT guidance from IDOH. But as a reminder, the new guidelines say that gonococcal EPT is permissible, and partner may be treated with a single 800 milligram dose of ceftriaxone. This is twice as much as the old dose recommendation. And then if chlamydia has not been excluded in the partner, then the EPT dose, the EPT treatment would be ceftriaxone at the 800 milligrams plus the doxycycline course for 7 days. So as we were implementing this in our clinic, the switch to the higher dose of ceftriaxone was really quite easy for us. We weren't worried about safety or tolerability of the higher dose. We just needed new information sheets to give to our patients about the higher dose, which IDOH provided. And then we had to get new packaging of ceftriaxone in the 800 milligram dosage from our pharmacy. The thing that was more concerning in clinical practice was giving doxycycline to female partners. So in the IDOH guidance for EPT, they say if the partner is pregnant or suspected to be pregnant, do not give doxycycline. Use instead the azithromycin 1 gram. But in clinical practice, sometimes it's hard for us to know as clinicians, or even for the patient to know if their partners are pregnant or not. So what we do is we ask the patient if they know the pregnancy status or birth control methods of their partner. We may be able to get some information that way. And then IDOH did update their partner treatment information to have some statements on there to the partner directly. So the partner that's receiving this EPT will also get an informational form on it that says, the medicines are very safe, but do not take this if you're pregnant, cannot rule it out, or are trying to become pregnant for the doxycycline component. There are still some scenarios in which case our clinicians may be uncomfortable giving out doxycycline to a female partner based on unknown pregnancy status. So there are times when we may still use azithromycin for EPT for female partners in combination with the ceftriaxone. Pharyngeal gonorrhea test of cure. So the recommendation is to collect this test of cure for pharyngeal gonorrhea at 7 to 14 days after treatment using culture and or NAT. As we were starting to implement this, one of our main concerns was about timing, and both presenters also spoke to this. We did have concern about false positive NATs if we were collecting these too early. Fortunately, at Bellflower, we are able to do NAT and culture for gonorrhea, so we're doing both tests for test of cure. But we've decided to routinely schedule these on the later end of the recommended time. So we schedule it 14 days out, 2 weeks out from their initial treatment. Another logistical concern for us is how would we schedule this follow-up and what would the visits look like? So any clinician that was treating someone for pharyngeal gonorrhea, they would go ahead and make this follow-up appointment for test of cure. But we knew we'd be missing some patients who had a clinic visit, say for urethritis or cervicitis, and we went ahead and treated that visit for gonorrhea. And then later the pharyngeal NAT may become positive because there are so many asymptomatic pharyngeal infections. So now to make sure that we're getting test of cure in those scenarios, we have our nurse at the clinic review a list of all positive pharyngeal GC specimens, and then they're calling to make sure that there's a test of cure for the patient scheduled. And then when a patient comes back for the test of cure, they're having a screening visit. So this is a visit just with a phlebotomist or MA, where the test of cure is collected. but it does not require a full visit with one of our clinicians. And I am happy to answer any questions now, or I have included my email here if you need to reach out.
Great, excuse me. Great, thank you so much, Dr. Heumann, and to all of the rest of the presenters from today. At this time, I know that we are at the top of the hour, but I would like to open this up for a few minutes of question and answers from our audience. So at this time, if you would like to ask a question, again, please feel free to access the chat window. Click on the chat icon to bring up that chat box, and then make sure your question is being sent to all panelists, so that way we can all kind of see that on the background and keep track of them as they are coming through. I wanted to start off with just a few questions here at the very beginning. So with that being said, I wanted to open this up to everyone within the group. So to all panelists, and feel free to just come off mute and kind of take it away if you'd like to answer this question. For newer public health professionals, how would you suggest talking to patients or the folks in their communities about resistance of gonorrhea, what that's looking like today, and how to better help ensure that patient and partner safety?
I can go ahead and start us off. I think it's important to let patients know that gonorrhea can develop resistance. There's this idea out there that I think some patients have, that gonorrhea is easily treatable. And so if they've had it before, they can just get an antibiotic and it's taken care of. So I think just letting there be some knowledge about the fact that resistance does exist in gonorrhea, and that we're starting to see trends that suggest that more of it may be coming. I think it's just the basic information that patients should know about, and that there's an importance in taking medication and coming back for testing and making sure that partners also are tested and treated appropriately. So I think that's the basics that patients should at least have. And then, making them aware of other resources that are available locally would be helpful.
Great, thank you. Okay. And then a next question for you all. This one will probably be more specific to Dr. Sear or Dr. Heumann. Are there any current variations to the Ceftriaxone 500 milligram intramuscular injection for patients who may be worried and or have some sort of extreme fear of needles or getting injections?
I can go ahead and answer that. That does come up sometimes here at Bellflower. A patient will say, I really don't want an injection today. Do we have any other options? And then this is another good time to talk about those considerations about resistance and how it's getting harder to treat gonorrhea. So I like to explain that our very best treatment right now is the intramuscular ceftriaxone. And then I also explain that the one alternative that we do have is the intramuscular gentamicin. So they would be getting intramuscular injections either way in that case. We could consider giving the Ceftriaxone at an 800 milligram dose. And I have done that for patients who absolutely refuse to get an injection. But I do try to avoid that because I know the ceftriaxone is more efficacious.
Great, thank you. Okay. And let's see here. Will the Indiana Department of Health be supplying doxycycline 100 milligram bottled in number 14 tablets for treatment of chlamydia? We currently get the bulk Zithromax from IDOH as one-time dose while in our clinic.
Yeah, so Deb, I can answer that. I will follow up with our CTGC program coordinator, and I'll check and see if we can get the different the different type of pill for you at the clinic.
Awesome. Thanks, Jamie. And then next, we had a question from Andrew. If we presumptively start a patient on 7 days of doxy at time of testing, then learn chlamydia is negative at site of symptoms, should we tell the patient to discontinue doxy or complete the full 7-day regimen?
That's an excellent question and something we've thought through at Bellflower as well. So we have decided, just because we have so many patients, that we aren't routinely calling back. So once we get the chlamydia result back, we don't call all patients and say, hey, you can stop the doxycycline if your chlamydia test was negative. But we have had patients call in to get their results sooner. And they, for example, we had a recent patient who told us they stopped their doxycycline. They had lost it. They only got a couple of days into it, but then their chlamydia test was negative. They only had gonorrhea. And so we said, well, you didn't need to finish it anyway. You don't have chlamydia. And then if patients were calling otherwise and we got their test results before they had finished the course, then I think it would be okay to stop the doxycycline early if they do not have chlamydia. But most of the time, we ask our patients to call back for the results at 1 week, at which point the doxycycline is pretty much finished up.
Great, thank you, Dr. Heumann. Okay, so we are coming up close on 10 minutes past the hour, so I'm gonna go ahead and take a pause on the Q&A portion of today's presentation. I know that many of you may still have some questions that you would like to ask our presenters today, either individually, or what I'm gonna also do is enter my direct email into the chat now. Feel free to email me any questions and I can get those passed along to our presenter over the next couple days, and we can get all of those answers sent back out to the group with some follow-up communication. So at this time, I just wanted to say thank you to all of our presenters. Again, today you all did an amazing job in giving our folks around the state plenty of information to help them move forward and help better to serve their communities and their patients within their clinics and health departments. If you enjoyed today's presentation and you would like to continue to learn more about sexually transmitted infections or a variety of other topics, please consider visiting HCET's virtual learning platform at learn.hcet.org. HCET's newest series, Sexual Health Concepts 2, will be live on June 29th, and then many other new learning opportunities are being updated regularly. So we greatly appreciate your time and attention with today's updated gonorrhea treatment guidelines webinar, and we hope to see you all again soon. Thank you.